Welcome everyone to our webinar on the Bennett Prize in Open Prescribing. Thank you so much for everyone coming along, and thank you for our speakers for being here today. I think we got quite a few of the attendees that are going to be here, so I think let's kick off. So we're going to have a few speakers today. We got Professor Ben Goldacre speaking first, and then talking about the Bennett Prize itself and his thought process behind starting that off. And then we also got Caroline and Richard, who are going to be talking to us about open prescribing, what it can and cannot do. But if I'm going to chair this properly, I probably should give an introduction about our speakers before we kick off. So Professor Ben Goldacre, most of you know him, but I'll give you a quick overview about him. He's a physician, academic, and science writer. He is the first Bennett Professor of Evidence-Based Medicine and Director of the Bennett Institute for Applied Data Science at the University of Oxford. Professor Goldacre is here to talk today about the drive behind the Bennett Prize in Open Prescribing. I'll also give you a quick overview about Caroline and Richard. So Caroline is a practicing pharmacist and clinical informatician at the Bennett Institute for Applied Data Science. She has experience in working at the digital transformation lead for a primary care network. Alongside her role at the Bennett Institute, she practices as a prescribing pharmacist within a GP surgery in Crewe. And last but not least, we also got Richard. He's an honorary research fellow at the Bennett Institute for Applied Data Science, focusing on the Open Prescribing project. He qualified as a pharmacist in 1996 and has worked as a pharmaceutical advisor for the NHS for over 20 years. He is currently also the Deputy Director for Medicines Optimization at NHS Devon. Now, I will hand straight over to Professor Goldacre, who will give you an overview of the prize, and then we'll have a hear from Caroline and Richard. Ben, over to you.
Hey, thanks, and thanks all for coming. So I'm going to talk a little bit about the origins of the prize and then the kinds of things that we're looking for in entries. So we're quite an unusual team in a university setting because we do our own research projects, of course, but most of what we do is building platforms and services and tools for other people to use. And so because of that, we get to see a lot of the great work being done by all of our users. So our two big, most commonly used services are, number one, Open Safely, and that's our data analysis platform that lets anyone who's interested to put in a form to come in and do analyses on the whole population's GP records, historically for COVID-only projects, but going forward for more general medical use. We also have made for a much longer period of time the Open Prescribing platform. So this is a fully open access service. Open Safety, of course, is locked down with lots of security provisions, and you have to apply to NHS England for access. Open Prescribing, by contrast, is a fully open service. So any interested person on the internet can come and see exactly what's being prescribed in each individual GP practice, month by month, down to the level of individual brands, chemicals, and so on. And because it's been running for 10 years, because it's its 10th anniversary, and because it's got such a huge number of users, it gets about 20,000 unique IP addresses per month and a few thousand subscribers to the data-driven alert service. We thought that would be the right place to start for our first ever Bennett Prize. So Peter Bennett is the benefactor who gave a grant a couple of years ago to endow a couple of chairs and also core costs for the Bennett Institute. And the Peter Bennett Foundation, from their core grant, we're resourcing this prize. And the idea is to showcase the best user-led projects using our tools and services. So starting with Open Prescribing, we're interested in anyone, well, hang on, let me think about practicalities. So first up, who can enter? Literally anybody. So Open Prescribing is open to a huge number, to everybody. So it has a huge and diverse range of users. You can enter this prize if you are any of those users. So we're interested in pharmacists and medicines optimization teams who use Open Prescribing to spot opportunities to improve quality, safety, and cost effectiveness of prescribing locally. We're interested in people who are GPs or other primary care clinicians or people working in general practice in other roles, people who are using the tools and services to spot opportunities to improve care there. We're interested in secondary care clinicians or commissioners of health services who are looking at data on prescribing in primary care in order to understand changing patterns of adoption of treatments in their field of medicine. In particular, of course, over the last decade or so, there's been a transition where almost all secondary care outpatient prescribing gets picked up in primary care. So actually primary care is also a place to see changing patterns of use and differences between regions in uptake and adoption of new treatments or guidance. Also for things that are initiated in secondary care, just because the prescriptions then appear in the primary care dispensing data. We're also interested in submissions from ICB staff and NHS analysts who are looking at this stuff at a regional or national level. Then, of course, there are lots of academics who use open prescribing, including people who've published papers on it in the past, in particular health services researchers and health economists. But outside of those NHS and university roles, we're also interested in students, members of the general public. We know that the tools are often used by journalists who use it to produce heat maps of variation in treatment choice across the country, policy professionals, think tanks, data scientists and developers who are just looking for an interesting data set to cut their teeth on. So really, absolutely anybody who is doing something interesting with open prescribing, we're here for it. In terms of the kinds of entries we're looking for, it really is, again, everything. So this is an experiment for us, this prize. I think in future years, we might be a bit more specific and opinionated, especially if we're doing things on open safely. But for open prescribing, in recognition of the size of its user base and the diversity of its users, we're looking things that are big or small. So even if it's just, I had a quick look at how we were doing in my practice, and we saw that we were outliers for not following BNF guidance on specifying the brand when prescribing this one particular class of drug. And then we did a quality improvement initiative to resolve that. And here is the graph showing that it has a substantial impact. We're interested in small things like that. And we're interested in big things. We're interested in things that are purely academic and very theoretical and data science driven, or things that are very, very applied and practical. And we're interested in things that are technically interesting, but also things that are foregrounding the clinical interest and the clinical value. So examples of things might include an opportunity to improve prescribing that you spotted in your organizational area using open prescribing data, and then a change that you made, and then using the prescribing data to follow up and see if that if your intervention had the expected impact. We're interested in maybe an unusual pattern or an outlier that you identified in prescribing data. So we often have people talking to us about how they spotted in prescribing data that there was a sudden increase or decrease in the use of a particular treatment, and then people kind of went on a policy document and evidence rabbit warren trying to work out what it was that drove that sudden unexpected change. It could be an academic paper that uses the open prescribing tools or data sets, or even just a blog post or a thread that was highlighting something quirky or useful that you discovered. The things that we're particularly interested in are things, obviously, that improve the quality and safety of clinical care. We obviously have a kind of deep interest in things that use data in novel or efficient ways. We're particularly keen on things that drive open science or transparent practice. So sharing your working with code is the sort of thing that we're particularly pleased to see, if there is code that you wrote. Or just share anything surprising, delightful, or important. Like I said, because the user base of open prescribing is so big and so diverse, we're really just here to see what are the interesting things that people have done in the data. In practical terms, and then I will stop rambling, the way that you enter is really very straightforward. Just write a piece explaining what you did using OpenPrescribing and post it anywhere online and send us a link. That's literally it. So it could be a LinkedIn post, it could be a personal blog, it could be a university website, it could be something on a social media platform, it could be an academic paper or a news piece or something in a professional journal. Anything that's got a publicly accessible URL, send us the link, and that is literally all you have to do. In terms of what you win, we will give out more than one prize if lots of good entries. The winning entry will receive the spectacular Bennett Prize trophy, which we are currently commissioning at our awards ceremony. And you'll also have the opportunity, if you can make it, to present your work at the Bennett Institute Oxford Medicine Symposium, which is December 10th and 11th. And we'll also feature and promote your work on the OpenPrescribing blog and the Bennett Institute website and our newsletter. And depending, I'm sure many of you relate to this, depending on the outcome of my conversation with the admin and finance team, there will be a small prize of minimal financial value in addition to all of that. So I think that's everything, but I'll stop there. And if anyone's got any questions, I'm happy to chat.
Not sure we've got any questions just yet, Ben, but we can jump over to Caroline and Richard to hear what they have to say about OpenPrescribing and how to get the best data and prizes out of it.
So I'm going to be talking about what OpenPrescribing is and what it can do, and then I'll be handing over to Rich to do a live demonstration. So what exactly is OpenPrescribing? Well, it's a free website which requires no login, and it lets you explore NHS GP prescribing. There is also now OpenPrescribing hospitals for those of you who work in secondary care. OpenPrescribing lets you zoom from national trends right down to single practice and drill down into specific drugs, brands, and doses. With OpenPrescribing Hospital, you can drill down from national to individual NHS trust level. It's got ready-made measures that flag opportunities for quality, safety, and value, but it also allows you to build your own analyses and set email alerts to keep an eye on the things that you're interested in. A question you might have is where the data comes from. Well, the NHS Business Services Authority publishes data of all prescriptions dispensed in community pharmacy. It lands monthly, usually with about a 2-month lag. The data they publish comes directly from dispensed prescriptions submitted by the pharmacy, so there's no linked information about the clinical condition the patient has or what medication it's treating. It's also anonymous, so we don't know who the patients are. OpenPrescribing hospitals, on the other hand, it uses hospital stock control data from the secondary care medicines dataset, and this dataset is also publicly available from the NHS BSA Open Data Portal. And everything we do is open. We publish all the code we use. So if you look at any measure on the OpenPrescribing site, you can click the View Technical Details link, and you'll see the exact SQL code and a link to a GitHub repository where updates are tracked. It means that it's always clear which drugs have been included, whether the measure's based on items or quantities, and exactly how the numerator and denominator have been defined. So what you're looking at here is a screenshot from the NHS BSA website showing a subsection of July's prescribing data from the Open Data Portal. That single month alone, as you can see, it contains over 18.5 million rows of data, and that's just for 1 month. So to put that into perspective, it's way too big to handle in something like Excel. And this is exactly why OpenPrescribing excels, because it takes this huge, complex raw data set from over the years, it crunches the numbers using clever data science tools and presents it to us in a way that's easy to explore and share in just a few clicks. And to give you an idea of what things are behind the scenes, I've just included a screenshot here of what the back end of a measure looks like, if you're interested. And like I've touched on, you can build your own custom analyses to look at specific drugs, groups of drugs, combinations of drugs, but a great place to start is with our pre-built measures. And these answer common questions like antibiotic stewardship or safe prescribing. And we try to keep things simple, and in general, lower is better for most of our measures. There are a few where it's not always, there's no general consensus on whether low is good, but in majority of cases, we try to go with lower is better. And each measure shows how an organization is doing compared to peers and whether the trends are improving or slipping. And as I've already mentioned, you can subscribe to receive alerts when the data is updated. I'm mentioning this again because I think it's really useful. I know I work as a practice pharmacist, and sometimes we'd have clinical meetings to discuss a particular issue, and everyone would agree that they were not going to prescribe a particular drug anymore. And then 6 months down the line, you find that it's still happening. So if you can get these updates monthly, you can keep an eye on things, and just so you can nudge the correct people if you notice things aren't going in the right direction. And I've got a screenshot here. So this is just from the OpenPrescribing website, just a snapshot of some of the measures that are on there. And I'm just going to show now a specific example. So here we've got the same measure for two different ICBs, and that's items that shouldn't routinely be prescribed in primary care. On both charts, the red line is the local sub-ICB. The blue dashed line is the national median, and that's just the middle point for across all of England. And the dotted blue lines are the national deciles. And when we say national deciles, this just means we've divided the country into 10 equal groups from lowest to highest. So if your red line is near the top dotted line, you're one of the highest prescribers. And if it's down near the bottom, you're one of the lowest. And comparing the two, you can see that the sub-ICB on the left has been sitting above the national median the whole time, a sign that they're prescribing more of these items than other areas and that nothing is changing. In contrast, the sub-ICB on the right, so yes, it started at a lower position than the other, but it has managed to bring prescribing right down from above average to below the national median and even to the lower decile. So a takeaway really here is that by looking at where your red line sits compared to the national bands and the deciles, you can quickly see if you're an outlier and whether things are moving in the right direction. And now I will hand over to Rich for a quick demo of what the best bits of OpenPrescribing are. Thank you.
Thanks, Caroline. Afternoon, everyone. This is OpenPrescribing. We all know what it looks like. Just to go through some of the bits and pieces that you can use if you think about putting in for a prize. We have lots of measures. I've used Devon here because that's where I am. We have 75 measures. And you can look to see what they're all saying, and to see if there's been any improvement, and to see if there's anything where you need to do improvement. One of the ones that makes me really happy, not this one. We are high hypnotic users in Devon. That's not good. But if you go into individual practices, there are practices that have clearly done pieces of work. For example, lead side practice, when it loads, use OpenPrescribing in order to identify really high use of their anti-epileptic hypnotics. Did a big piece of work on it a couple of years ago and have managed to halve their use. Being able to find that, being able to track that use and that change is really powerful. So that's our measures. We've also got the 24 items that should not be routinely prescribed in primary care measures as well. Amiodarone's going up. That's because the cost is going up rather than anything else. We've been less successful in managing liothyronine locally. But there are 24 measures there that you can look at, which will help you identify areas of behaviour. We've got the price per unit tool. This shows where there are opportunities for saving money against different brands or different formulations. We've recently updated this. It used to be run on a manually updated spreadsheet. We've now written an algorithm that allows us to add and remove stuff automatically. And we've now got 4 times the things in here that we used to have a couple of years ago. I'm going to pick one, not the beclomethasone one, but I'm going to pick venlafaxine as an example. You can see here, if we look at my ICB, we've got quite a bit of generic prescribed modified release capsules at 34p a capsule. Currently, the modified release tablets are 11p. Could you change some of those people over whilst maintaining clinical effectiveness of that? Quite possibly, it's worth having a look at. So we have lots and lots of those to do that. I need to move that thing out of the way. So price concessions, nothing much of us can do about it. Where a drug has become expensive due to unavailability, we email out price concessions and provide price concession information for every practice. PCN, sub ICB and ICB, and you can see exactly what's going on there. So for example, indapamide is a price concession in September, would normally cost us about £6,800 in Devon. It's currently costing us an additional £80,000. It's quite a useful tool to track what's going on. As I say, there's not much you can do about it, but it's really interesting. Next, ghost branded generics. So this is a tool to find where strange stuff has been prescribed at a high cost per unit. Often where a practice has got something like apixaban 5 milligram brackets Teva on the prescription. It's prescribed generically. It is processed as a generic script. The pharmacy or dispensing doctor should dispense only the Teva brand, but the Teva brand is several times more expensive than a generic one, and that is what is paid for. So this tool helps you identify where those things are happening. Not too much by the looks of things at the moment in Devon, which is good, but it will help you identify areas of cost that you might be able to improve on. We've also got the national tools for both BNF sections and BNF chemicals. Is this the right one? Yes, it is. So not much happening there. There used to be a much more interesting seasonal variation in there, which doesn't seem to be happening then. I think that's probably because I picked the wrong one, but let's not worry about that. So this allows you to identify BNF chemicals in terms of cost and spend across the country. So if you're doing research on different uptakes of drugs and you just want to look at it at a national basis, you can do so much more quickly than running different things in the analyze page. You can also download all of that data either for national or sub ICB location if you wanted to go away and analyze that data further. We have the drug tariff, which is another useful tool for people who are keeping an eye on cost of drugs. Take example, apixaban recently lost its patent. Hopefully it will pop up in a second, and you can see used to be expensive, went very cheap, then a price concession came in, so we mapped that separately and allow you to track what's going on and try and find different products if you need to. A couple of little things I want to pick up which are less commonly well known about OpenPrescribing. The first one is our DM&D browser. Carol and I were talking about this morning, and we were talking about trying to find hydrochlorothiazide in preparations and how much is used in a practice. And actually, by using this, it's a really quick way, this is where I spell it wrong live, of course, a really quick way of finding products that may be striped across multiple preparations, because a lot of products, including hydrochlorothiazide, are in combination products and you have to go and find them all. If you use our DM&D browser, which can be found by clicking on more, and then I can't see that because of where the sharing tool is, that, and then DM&D. So you can see here, it finds 51 different products, including enalapril and hydrochlorothiazide, metoprolol and hydrochlorothiazide, olmesartan and hydrochlorothiazide, etc., etc., etc. So if you want to just find something that's got that product in, that will then take you straight to the analyze page for drugs as well. It's thinking about it, which is why it's not doing it. There we go. And so it picks up all those drugs at a chemical level and allows you easily to find how much is going on. Let's just have a look at Devon for a minute. How are we doing in Devon? Oh, we don't prescribe a lot of it, so that's okay. So we prescribed 158 items in the last month. So that's a really useful tool that might well be worth being used if you're wanting to find different things. And finally, we have the improvement radar, which has just been updated today. This shows you where sub-ICBs have done pieces of work that have improved matters. They had to be bad prescribers in the highest 20% and then moved to the lowest 20% within the period. And we can see, let's pick one that I know that I would say this Devon are good at, vitamin B complex. So we did a lot of work in Devon. We used to be really high users of Vit B complex. NICE doesn't really recommend it because of the thiamine content. And over the couple of years ago, we did a big piece of work to remove people from it onto individual thiamine products, so a much better thing for the patient. And the idea of the improvement radar, which can be found by going to trends and then pulling improvement radar, is try and find out if you're struggling on how to do a piece of work, find someone else that has done it and managed to improve it, and then give them a call or drop them an email or whatever it might well be to just try and help spread good practice. There is one more thing that we need to just talk about briefly, but I'm not going to talk about it, which is we've recently brought out OpenPrescribing in hospitals. So for the last 10 years, we've done OpenPrescribing in primary care. In the last few months, we've brought out a prototype version of OpenPrescribing hospitals looking at secondary care medicines data. And my colleague, Vicky Speed, who's a clinical informatician at the Bennett Institute, is going to just take us through that now. Vicky.
Right, this is OpenPrescribing hospitals, OpenPrescribing's new little sister. So I'm going to give you a whistle-stop tour. There might be entries from OpenPrescribing hospitals, but it is very new. So we just wanted to take this opportunity to show you that it's here and how it might be of use to your organisational quality improvement plan in your organisation. So this is OpenPrescribing hospitals. You can get to it from OpenPrescribing or just stick OpenPrescribing hospitals into Google, you'll find it. So for those of you that are OpenPrescribing regular users, you'll see here that we have got some familiar features. So OpenPrescribing hospitals has got 3 features at the moment in its sort of early beta edition. We've got submission history, measures, and custom analyze. So measures and custom analyze, they're basically based on the same principles as OpenPrescribing. Submission history, we weren't expecting to build, but then we did need to build it, and that's because of the data on which OpenPrescribing hospitals sits. So OpenPrescribing hospitals is different to OpenPrescribing because the data on which this is sat is processed pharmacy stock data. And that data is openly available, hosted on the Open Data portal by the NHS PSA. But it's prepared and curated by RxInfo, so a third-party organisation, but they're taking all the submissions from all of the trusts in England, putting it all together and packaging up those monthly CSVs. So there's lots of different feeds of data coming in for to put together this data set that is reliant on those trusts. So we had to do submission history because we kept seeing that sometimes some of the data wasn't there or didn't seem to be all there. So we needed to make it easy to see where data might be missing so that it meant that you're able to analyze, to meaningfully interpret the charts that we're providing via analyze and in the measures feature. So just by way of example, and you could search by region ICB here for the particular trusts that you're interested in, but I'll just give you an example of an occasion when sometimes data is missing. So this is a hospital in London which had a new EHR system put into their trust, and it meant that there was an outage of data for a period of about 8 months. So if you're looking at then as a chart on the analyze page and there's it looks like you've got a low prescribing rate of something, it's not because that's what's happening at the trust, it's just the data wasn't submitted. So we need to make sure that it's clear to people using the platform that there is data or there isn't. So that's why there's a submission history feature, which isn't something that you would need on OpenPrescribing, but by the very nature of the data on OpenPrescribing hospitals, we do think it complements the other features nicely, where you see something unexpected. So that's submission history. I'm just going to show you analyze. So you can search by product, ingredient, and a little bit different to, well, we've got ATC code, so you could use that as well if you wanted to group some products together. I'm going to give you an example of my favourite drug. I'm an anticoagulant pharmacist in my other life, so I'm quite predictable. This is what I like to prescribe. So let's look nationally at how much apixaban is used. And we can see what we can do on OpenPrescribing hospitals. So you can see the 2 strengths of apixaban there. We're using DDDs, so we can put the 2 strengths together, and you can see the general uptick of apixaban, and that's again a percentiles chart, the same as what you might see on OpenPrescribing, just presented a little bit differently. We can see the trust usage in different time periods here, so you can see the biggest user, Birmingham, Manchester, Barts. These reflect the size of the organisations, and approx, not surprising. Now, of late, we've had to use less edoxaban, so let's stick that onto the chart as well. So now we've just released a multi-product feature, so we can put 2 products next to each other. When we started out, we wanted to get something out onto the internet to have a go at using the platform, so we did a single product search. But just in the last month, we've been able to add the multi-product search, so you can start to put different products next to each other on the chart, run analyses on more than one product. So let's see how they compare. I'm going to put my own trust in here and see how we're doing. So let's see if we've stopped using quite so much edoxaban. Okay. So I can see the products that have been included here. That's everything I would expect to see. I'm going to break that down by ingredient. And I'm pleased to see our use of apixaban is going up and our use of edoxaban is going down. So that's the analyze feature. And the final thing to show is measures. So very much like OpenPrescribing, we've got lots of measures, pre-curated analyses that we think might be of use to people working in clinical practice, and we base all of these measures on national standards. So one of the ones that we've got here is the use of lidocaine plasters, and we've taken this, we've done this one in secondary care to see if we could apply the same principles, that ideally this is a low value medicine and we should see the use of this declining. So we can see here, here's the measure. We've got the percentiles chart that Caroline showed before, with the red line showing the median use there. And the y-axis here is the quantity, literally the quantity of plasters being issued from each trust each month. So this tells us the median. So let's have a look at putting all of the trusts on here and see if we can see, okay, bearing in mind we should be trying to reduce the risk of reduce the use of lidocaine plasters. Who's using a lot? So we can hover here and just see, East Lancashire Hospital is using a lot, but more concerning, it's going up. So if you're at East Lancashire Hospital, you could take a look at this chart and see how you could improve or reduce the use of those lidocaine plasters. So the other thing you can do here is look at the region and see if there's any regional differences here, and that might be of use to ICBs or regional level organisations to see about, okay, where have we got a problem? Then you could drill down into the trusts that might be driving that. And it's no surprise to see the Northwest up here, based on what we've just seen from that particular trust. So that is a whistle-stop tour of OpenPrescribing hospitals. There's lots of other measures to take a look at here. So we've got 12 now. So we'll soon have to have a new menu for our measures page. But yeah, please have a look. We'd love to hear your comments and feedback. And if you can think of it, an audit or something to submit to the OpenPrescribing Prize for OpenPrescribing hospitals, that would be amazing. Thank you.
Thank you, Vicky. Just one quick thing. I forgot to mention the API, which some of you may well be using for the prize, and that pulls the data out of our server, so you can do your own analysis in different tools. You can use it for different things. Here I've got some examples. So if you wanted to look at both SUVA 20 and 40 milligram tablets, you can run that at an England level or a lower level as well. There are various things you can do by that. Do it by practice, by ICB regional, by regional team. You can pull things like list sizes and that sort of thing, may be quite useful for people. What I would say is, if you are going to use the API, please do so. That's great, but just be careful if you want to pull individual practice / presentation level stuff out, because from time to time people run it iterating over several thousand times, and it sometimes kills our website. So if you're going to use it for lots and lots of data, can you please drop us an email first, just to make sure that it'll work.
Very good. So open to Q&A now, please. So if anyone's got any questions, please type something down, or even better, raise your hand. But as a good chair, while we're waiting for questions to turn up, I've got off some of my own. So this one's for Ben, I think. What does good look like? What kinds of entries would make you excited? Novel methods, practical skills, or sharp insights?
Well, like I said, this is a very inclusive first round. I think in future years on stuff like Open Safely, we'll have some quite specific prizes around academic research papers, but with Open Prescribing, there's such a vast reservoir of people doing their own stuff out there that I have no strong preconceptions about what sort of stuff we're looking for in this first prize. And it is unusual for me to say that, I can promise you.
Very good, thank you. And I think this is more looking towards the future. What impact would a successful first year of prize have for the NHS, academia, and or the public?
Well, I think you might expect me to say this as a geek, but I feel like the work that's done by, in particular, data analysts in the NHS is really under-recognised and under-rewarded. So we're keen to do everything that we can to make that kind of work more visible and higher status. So this is one small contribution to that. And if you'd like to read more of my views on how to make NHS analytics great again, chapter 4 of my review for Secretary of State in 2022, better, broader, safer uses of data in healthcare.
Okay, we have a question from one of the audience. They'd like to know, if they want to explore a drug in both Open Prescribing Hospital as well as Open Prescribing GP, what's the best way to combine the approach to get one result?
Well, that's not a question of the kind of mathematical operations. It's narrative. So prescribing in primary care and prescribing in hospitals are two kind of very different things operationally in the NHS.
So some of it will depend on the drug. So I was thinking about Vicky's one earlier about apixaban. If you were to pull the total quantity of apixaban out of Open Prescribing and then adjust that for the DDD for apixaban, which can be found on the WHO website, you can then get a total system value across both primary and secondary care, and that's fine for that. There may be some that are more tricky, but it will depend really on the drug.
Yeah, I was going to say the same, Rich. And we've done some work with lithium across the system, if you like, and we pulled together Open Prescribing data and Open Prescribing hospitals, and actually prescribed in the hospital, dispensed in the community. So we put the 3 different open data sets together, and we used DDDs to do that. So that's kind of one of the ways, or the way that we've used to sort of put them together. Although it's probably worth appreciating the difference in where that data's come from. That the data from Open Prescribing hospitals is stock, so it's not necessarily been prescribed to an individual patient. So it's worth thinking about how that's been issued in the hospital. Has it been issued to a ward? Has it been, or would it be most likely to have been prescribed to an individual patient? So that's worth just taking into consideration.
And Hayley, who was an HDR UK Health Data Science intern with us over the last few months, wrote a blog about it, and I've put that in the chat. So
fantastic. Any other questions before we bring this to a close from anyone? Or anything else Ben or Vicky or Caroline or Rich want to bring up? No. Okay, fantastic.
Write your stuff up, send it in. We're keen to see it.
Yes, we've had 9 submissions so far. The closing date is the 10th of November. Now that might feel like a long way away, but these time deadlines come up quickly. So don't just sit on it. Start today. Start writing it today. Submit it today. You know, we want to see them. We want to get great quality things, interesting things in, and you know, we're looking forward to presenting the best winners at the Bennett Symposium Conference in December.
All right. Bravo. Cheers all.
Thank you so much, everyone. Bye for now.